Hi, everyone. Welcome to the RNS COVID-19 Facebook Live event. And we're so happy you could join us tonight. So make sure that you share that you're live with us tonight and like us, love us, show us, what you're thinking about what we're talking about tonight. We're going to do something a little different. We're going to have some flashbacks on some previous episodes and talk about how things have changed along the way with COVID and from those conversations to now. And we have some other nice little things for you too. So tonight I'm actually joined by Laura Kimball, who is a nurse researcher from Emory University and also a board member of the RNS. So thanks for being with me today, Laura. So you have a two-person panel tonight. So we'll just call us a dynamic duo tonight. So what we're going to do, so we always start with around the neighborhood. So I'll go ahead and go first. I'm Kathy Patty Rusk. I'm a pediatric nurse practitioner from Detroit, Michigan. I work at Children's Hospital of Michigan in the Division of Pediatric Rheumatology. And so I'll give you the statistics in our neck of the woods today. So in Detroit, we have had 11,840 cases, confirmed cases, and we've had 1,449 deaths, with that giving us a case fatality rate of 12.9%, which is very high. The national average for a case fatality rate is actually 8.9%. So we're quite a bit higher, 3 percentage points higher than the national average for fatality rate. And I have some thoughts about that. We can talk to you about that in a minute. Laura, what's going on in your neck of the woods?
Yeah, so I'm Laura Kimball. I'm a nurse researcher from Emory University, and my area is I'm a symptom scientist, so really looking at lupus symptoms and how that affects quality of life and other health indicators. So I do reside in Georgia, and it's in Atlanta. And so right now in Georgia, we have 103,890 confirmed cases. We have 2,922 confirmed deaths, so really approaching almost 3,000. And we have 2,215 individuals that are currently hospitalized. So our number of cases is going up in Georgia. And actually, I think it was yesterday or today, the mayor of Atlanta actually requires masks now in the Atlanta city area, which is a little bit different than what the governor has required in the state. So it's sort of been more optional, but we're finding more and more cities within Georgia, I think starting with Savannah, are requiring masks. So definitely cases are growing in Georgia, and there's concern here.
Well, I thought it was interesting that the um, that the mayor of Atlanta did that after she announced that she tested positive for COVID.
Yes, that's right. I think, I think that she's been in a really difficult position because Atlanta has had, a lot going on, and but she was one of an important official to say that she had tested positive. So I think she said something like it's really hit close to home, and it has for her.
Yeah.
But we have within just the Atlanta city, a lot of populations at risk. There's more individuals of color there and things like that. And I feel like she really felt a kind of a duty to the community to put these, safety measures in place. And I think she has a lot of support for that.
Yeah, I agree. I mean, we need more
Hmm.
of these, public officials and, um, high profile folks to come out and say, yes, I tested positive. And, if they had some careless exposures, to talk about it, because I
Hmm.
think we're all getting stir crazy. We're all get back to our lives. Summer is here, and this is when we all vacation and, hang out with friends and, have fun. And it's just kind of human nature for what we want to do in the summer. And you can't blame anyone for not, for being careless, because it's hard.
I think it is hard. And I think, it reminds me of just how complex public health messaging is, just overall. When you think about the fact that, when we started on this journey with COVID-19, there were scarcities in PPE. And there weren't these availability of cloth masks that now are being, manufactured and you can get. And so I think there was a somewhat of a decreased emphasis on wearing a mask just because they wanted to be able to say those, for healthcare workers and individuals that really needed them to be safe in the healthcare system, and they didn't want people walking around going to the store in a surgical mask. But I think kind of what that did was it maybe decreased the emphasis on the importance of a mask. And now to kind of come back and say, yes, wearing a mask is really important. I think sometimes people don't understand, well, if it wasn't important at the beginning, why is it important now? And some things like that. And I think it's not anything that anybody did wrong, but it was just a way to kind of save PPE and initially.
Yeah, I don't think the public really understood the predicament that we were in the healthcare industry with the lack of PPE, um, because it was just critical, and just changing the way we've had to change our whole thinking as healthcare providers about PPE. We were always taught that you go, you gown up and everything with your PPE, you go into the patient's room, you take care of them, you take it off when you exit the room. And then when you go to the next patient's room, if they need, isolation and you have to put PPP on, I'm sorry, PPE on, you put it on for that patient. So we would never think of using the same gown or the same mask or anything to take care of another patient. We've just been taught you don't do that. That's really bad infection control, practices. But then when COVID came and PPE has been so short, we've had to do that. I remember when I was told when I had my first N95 mask, recently, and I was told, all right, make it last.
Yeah.
It needed to last, several days to a week. And, it was recently that I found out that I can actually get a new one every day now. But now I'm kind of in the habit of using mine for about a week or so before I get another one. So it's just a little different.
Yeah.
And I think we're even more cognizant of trying to preserve our supply and not waste it. Right.
I think that's very true.
I don't, even though I can get a new mask every day, I don't want to, because I don't know what's going to happen. What happens if we start having a shortage again? I don't want an ER nurse or an ICU nurse to do without a mask because I change my mask every day.
Right.
It just it doesn't feel right now, which is a total flip from a couple months ago.
Right. I mean, sort of the ethics of
Like, whoa.
PPE, was not even on our radar, right? And now it's become just such an important thing of just an ethical and moral issue about of how we use,
Yeah.
scarce resources. So it's just a very different narrative, around these things that are just kind of a part of, nursing and healthcare that they're disposable and you get rid of them. So.
Yeah, it's so funny. Yeah, so it's just interesting how we've done things now. Um, so before we move on, I want to take a time out for a commercial break here and talk to everyone about our conference. We have our RNS. I believe it's August 3rd, 5th, 8th. Oh boy, Kevin's going to kill me. But early August, you can find all the details on our website. It's a virtual conference. We don't want to get anybody sick, and we don't want to have to pass out all that PPE for you. So it's all virtual. We have some great speakers this year that you'll really like. And I'll tease you later on and tell you who some of those speakers are. I'm not going to tell you yet. But we do have, for RNS members, to register for conference, it's only $99. And you do get lots of CMEs with that. So it's well worth your money. And abstracts, the deadline for abstracts has been extended to July 22nd, which Laura knows all about. She's taking care of that for us. And we have the Armstrong Scholarship deadlines, which have been extended to July 30th. So if you know anyone that is in nursing school currently and have a special interest in rheumatology, whether they be a patient or not a rheumatology patient as well, certainly apply for our Armstrong scholarship. It's well worth it. I believe it's $1,000 scholarship to be used towards your education.
Hmm.
And all we ask is that you write us just a real nice narrative about why you think you're deserving and why you're interested in rheumatology. So, spread the word because we want to give it away. Anne Strong was a rheumatology nurse, was a nurse and a rheumatology patient, I believe. And when she passed away, her family gave us the scholarship funds to continue this for her in her honor. And so it really means a lot to us to help honor one of our fellow nurses and keep her memory alive and support her family at the same time. So we encourage everyone that qualifies to apply. And let's see what else. Let's see the membership abstracts. Okay, well, that's it for right now. My commercial is officially over. So let's take a look at, we're gonna do something a little different. We're looking back on COVID-19. So let's take a look back at one of our clips from Dr. John Mooney, who talked to us about the vaccine with COVID, the COVID vaccine. So let's take a look and hear from John, Dr. Looney, and then we'll come back and we'll talk some more. So talking about schools brings us to our special.
Well, I think that, I mean, this is a very infectious virus. It's going to go through the population. I think the immediate goals were to try and make sure that it didn't overwhelm the healthcare system like it did in New York City and Italy, and so that's why the old epidemiology, hygiene kind of things had to be implemented. The social distancing, the hand hygiene, the use of masks, things like that. That's the only way you can slow down this kind of a virus, but we're not going to stop it. It is going to continue to spread. It's established in the communities. It's going to continue to be a problem until we get enough immunity that it doesn't spread so much. And then it'll still be sporadic probably. So, you're going to get the herd immunity that everybody wants to talk about, either because the virus itself has infected enough people, but if it does, there'll be a lot of deaths. Okay,
Mm-hmm.
The hope is that we can, the people who are highly vulnerable, includes me because I'm almost 70. I'll be 70 in July, so I have to be considered one of the people that's vulnerable. My strategy is I don't want to get it before I get the vaccine. And the vaccine is not going to be like the measles vaccine. The measles vaccine is just a miraculous vaccine. It's like vaccinia for smallpox. I mean, you get immunized, you don't get the infection. It's as simple as that. Here, it's going to be more like the flu vaccine. The flu vaccine actually doesn't prevent you from getting infected with the flu very well. I mean, it makes an IgG antibody that protects your lungs. It doesn't protect your upper respiratory system. If you get, they do have for the kids, they have a live vaccine for flu. I think it's back this year, where it's a live attenuated vaccine. They make IgA in their upper respiratory tract, and so they're actually protected from infection. But the intramuscular vaccines don't protect you from infection. They protect your lungs, and so the flu vaccine is much better at preventing death than it is at preventing infection. So I like to tell my patients, we don't give you the flu vaccine so you don't get the flu. And they all look at me, and they said, we give you the flu vaccine so you don't die of the flu. And I think that is the data. It's probably 80% effective in preventing death. So it's very effective at reducing, hospitalizations, ICU admissions, and death. And thanks to the fact that it's used so widely, we don't have 100,000 flu deaths every year. but we still do have 20 to 40,000 flu deaths every year. And if the COVID vaccine can be as effective as the flu vaccine, I'll be happy. That'll reduce the number of deaths tremendously. But if we have to rely on natural infection, there's going to be a lot of deaths among the vulnerable people, unless also we get a very effective antiviral. But you'll notice that they're developing antivirals and they're developing these the convalescent serum. They've got monoclonal antibodies, but all of those things only work very, very, very early in the disease. If you look at flu or if you look at RSV, where we've been using those drugs for years, their primary efficacy is very early in disease. And so, right now we're using all those things very late in disease because we don't have very many of them. And so they may work much better if we can use them early when we've ramped up enough, but we'll have to see what happens.
All right. Wow. Those are some great comments from Dr. Looney. I think there are several things in there. Just a reminder of how serious this COVID-19 is and where we could actually end up if we're not careful. I think with everything opening up, we've kind of forgotten how dangerous and deadly this virus can be. And we're seeing more testing and more confirmed cases. And it looks like the death rate is falling, but I think we're getting a false sense of security with that. And it's concerning that we might, with so many young people being infected now, I worry about some of the older folks, myself included. I mean, I'm getting to that age. I don't think COVID recognizes that I haven't had my 60th birthday yet. So, I don't want to get COVID. I am very concerned about getting COVID because you just don't know. We keep hearing more and more things about people that are having side effects from it, long-term neurologic consequences, some cardiac consequences, and I'm not a gambler, and there are just too many unknowns to gamble with it. But one of the things that really I found really interesting about Dr. Looney's comments was when he talked about the influenza vaccine and how it really protects your lungs more than anything. How many times do we hear patients say, "Oh, I'm not getting the flu vaccine because I got it and I had the flu before." And, I always say, well, it's not, so you don't get the flu. So if you get it, you won't get as sick. And I've never really, I guess maybe I just didn't know about how it protected your lungs so well. But I think that's a really good point and something to start sharing with your patients, that the flu vaccine really protects your lungs. So I think that was really interesting. What did you think, Laura? What were your
what my aha moments are? I thought there was a lot to unpack in what he had to say because I think there was a lot of things in there. One of the things that kind of struck me was talking about just kind of, or what makes me think about is sort of the natural history of things. If we don't do, like viral spread, if we don't do anything to protect ourselves, right? And I think sometimes in ways we don't understand or don't maybe appreciate just the kind of the science around our understanding of what viruses do, and that if we don't follow these guidelines that have been, that are based in epidemiology, right, about what we need to do to prevent it, then we're going to have this, it's going to do what it does naturally, right, is spread. And kind of how he was saying that it consequentially, we're going to have more deaths unless we do something. So I thought that was really, and interestingly, kind of what he said is sort of what we're seeing now, right, as places have opened up and kind of just sort of ignored in a way what we know about epidemiology. We are seeing the result of that. The virus is spreading, and you're right, it does spread from young people, but then to older adults, and we're going to see more deaths. And I think if it goes from young people back into maybe older adults who have been sort of social distancing and isolating, right? So I think that's really interesting. And I thought the same way about the idea about the the virus, that the vaccine for the virus. I think there's been some people that have kind of seen it as sort of like the um, golden ticket right back to the lives that we had before. And I think all of us, and including myself, wow, I would really love that to happen. I think there's
Yeah.
nothing like the pandemic to have shown us, like, oh, how we loved, being in a crowd and all these things, and being able to
Right.
go to sports events and all. And so that kind of what struck me is like that's probably not going to be the case. That it's not some golden ticket. If it doesn't prevent it completely, and certainly it'll be wonderful that it reduces the hospitalizations and the deaths and the ICUs, but we still are going to have people that are going to be ill. And so we have to kind of, I think, maybe have a realistic expectation of what these vaccines are going to do. But a lot of really thoughtful things to think about in his comments, for sure.
Yeah. And I was talking with some of the residents at work today, and we were talking about how there are different levels of severity of the COVID with
Mm-hmm.
people, and how someone actually tested positive for COVID, had some on the more mild symptoms, and then later had antibody testing done and was negative. And so, you know, it so, what is happening? Are we seeing some, cross reactivity from previous coronaviruses, where we're getting some kind of like a T cell response or something there, which means that if this is what's happening, we're never going to achieve herd immunity.
Mm-hmm. Yeah, it's interesting.
And
Yeah.
right, because we
But
haven't really talked about that.
yeah, no, I mean, in fact, I think, one of the first kind of most visible cases of COVID-19 was Tom Hanks and his wife, right? They were in
Oh,
Australia,
yeah.
and they isolated themselves and everything. And I saw them interviewed, I think, yesterday, and kind of what they were saying is that they've been monitoring their antibodies, and what they found is that it's diminished over time in terms of the antibody levels. And so, sort of getting to the same thing that you're saying about, we don't really know, even, yes, once you're infected, can you be reinfected, and how that would work, and what that trajectory would be. And I also had heard, and I'm sorry, I don't know the source for this, but they were kind of saying as the virus mutates, that it may be in a situation where it causes less severe symptoms, such that if it was so severe, if it killed everybody, its main source of being able to stay alive would be gone. And that they say that's one aspect of how viruses work and how they are able to perpetuate themselves, that they sometimes mutate where they cause a lot of symptoms but yet not death. And that's where some of these people that are saying that they're having very sustained kinds of symptoms over time, even though they weren't in the ICU, but they're still having fatigue or headache and things like that, is part of the virus mutating, is what I understand. But, or perhaps that's one maybe hypothesis of what's going on.
Mhm. Yeah, it's really interesting. I think Dr. Looney was talking that desperation and almost fear in his voice when he was talking about having more deaths because we kind of let this get out of hand.
Hmm.
Um, and I think the conversation now has been I, I I see people steering away from having hard conversations about it, like
Hmm.
conversations that are being held in the public, realm with even with our, NIH folks and everybody, they're all, positive.
Hmm.
It's not that um I don't know, I guess people are afraid to just sound like too negative, like negative
Hmm.
Nancy or something, when it's actually a realistic conversation that I think should be had. I don't think it's anything to just kind of poo poo and, forget about because we keep, just like what happened with masks, right? Oh, save, you don't need masks right now. We need to save them for the healthcare professionals. And then we see how now that we're trying to get the public to wear masks, we're having a problem. So
Mhm.
now we've, been talking in a very positive tone to the public about how, yes, we're working on vaccines and we're going to social distance, we're going to do this and that, and it's working, it's flattening the curve and all this really good stuff. But no one's talking about the fact that we may never achieve herd immunity, and that talk about, you know, you may need, another a shot for it, like the flu. But no one's really talking about, how long it's going to last. Like if people are already having antibodies that are waning, what's the vaccine going to do? How long is that going to last for? Are
Mhm.
people going to need to get vaccinated every 6 months? I
Mhm.
mean, this is, becoming more of a reality, I think, the more we learn about it. And I think some of these hard conversations need to start happening.
Mhm. I agree, and I also think the kind of the hard reality of the unknown, it's sort of like, to me, is sort of emerging. I think for me, that's the thing that is sort of I see a lot in the conversations around me, is just sort of how we thought we could predict and we had sort of an action plan, and it just seems like that sort of the future is sort of unknown and unknowable, kind of, about how
Hmm.
hard it is to navigate a situation like that. And
Yeah.
so I think it's that hard conversations, but peppered with hope. But it's just that we just
Oh,
don't
yeah.
really know a lot of this, right? Yeah.
Right.
Mhm.
Right. I understand, we need to give people hope, of course. That's what we're all, we're all hanging on to hope. If we didn't have hope, my goodness, this would just, put us all in a bad state of depression.
Mhm.
It's hard enough coping with the new social distancing and, going to work and, the N95 and everything else, and just sweating underneath it. And it's just different now. Um, but anyways, I think we have a from, I think Pat Beer-Waltis is up next. And let's hear what she had to say about COVID and nursing schools, nursing education. So, talking about schools brings us to our special guest, Pat. So, Pat, tell us what's happening with the university and nursing education. What are the plans? What's the talk?
Well, I think it might be a good idea to start like where we were when this all hit. Um,
Oh, yes.
and then we can kind of fast forward to what's going to happen next. So
Sure.
when this all hit, I think all of us were in the middle of a semester. Um, we're fortunate that our undergrad program has a very active simulation lab and has recorded simulations for years. And so we have this whole library that they were able to draw on, which has just been fantastic to support them. Now, the schools of nursing get to decide how many hours they require. And the Board of Nursing kind of oversees that. As long as you have enough hours to meet the criteria, then you can go forward. So there's been a lot of talk between the universities and the State Board of Nursing, no matter what state you're in. And in fact, the National Council on State Boards of Nursing put out a document listing all the different states and what adjustments the state boards were allowing to get students through the semester. So for example, in Michigan had one of the most clear mandates, and that was that if you're a nursing student on track for a degree or to get your RN, then you can work to fill an area of need, and that can count towards your clinical hours.
Wow.
So, we kept seeing calls in Minnesota, there was a huge need in extended care facilities for nurses. And so there was some talk on if we needed to. Now, when that need really came in Minnesota, we had already ended our semester because our semester ends the first week in May. But there was talk of like, could we use that in the fall possibly as clinical hours for students who need it, because that is still considered an area of need. So that was kind of where we were with undergrad. We are way over what's expected in terms of the number of hours our students are required. So those students who were seniors about to graduate were able to essentially finish the program by doing their didactic work and completing some simulation hours. Now, each state board of nursing also looks at what percentage of your clinical hours are replaced with simulation. And in Minnesota, that can be up to 20%, but they were allowing schools to go higher than that if they needed to move students forward in a program. So in our graduate program, it was a little bit different because we were getting mixed messages. You know, we have students like all over the state. And so some healthcare facilities are like, yeah, the students can still come. In fact, Mayo was one of the institutions that held on the longest to letting nurse practitioner students come to clinicals. And then all of a sudden everything got pulled because guess what? Mayo was furloughing their clinical employees because clinics were shutting down here just like they were everywhere else. So what we were able to do with those students, now those students actually graduate the end of July. The recommendations are really a minimum of 500 hours in the program, and we're at 700. So wow. Going into this summer, they were in good shape. So I teach the spring semester of our nurse practitioner cohort, which is their PEDS semester. And sadly, there are some students that only had, you know, they were like 30 to 40 hours short. So we lowered the requirement from 150 to 100, and I still had students that were short. So we found some really interesting ways to let them fulfill their requirement. There's some online programs. One is called Aquifer, which you may have heard about it if you've worked in a nursing program or know somebody in medical school, because many medical schools also use that. They give cases that are evidence-based, they're peer-reviewed, they're continuously updated so that it has best practice and follows guidelines. And they're somewhat interactive, you know, so I could assign a pediatric case that was perhaps a, you know, congenital heart disease. And the student would go into an exam room and meet with a mother and be able to ask questions, you know, maybe select from a menu of things of what they thought was important. So it's kind of cool in how it lets your student choose things and still be involved in the decision-making from assessment all the way through management. There's another program called PEDS Cases that too lets you build from assessment skills. It's a little bit less interactive, but it has videos and podcasts and different things that, that can be useful. We also were piloting, and unfortunately not for this cohort that was in clinicals, but for our cohort that was learning assessment, a program called iHuman. And iHuman has virtual patient encounters that allows interaction in really a comprehensive way from history through diagnosis to management of the patient. And they have over 350 graduate cases. So wow. It's kind of cool because you can actually like show where you want to put your stethoscope on the avatar. And, you know, so it's very, very interactive. It's also kind of expensive. So we're looking at using it again because not only do we have COVID, but we have historically, and I think this is true of many nursing schools across the country, had difficulty finding preceptors. You know, there are some institutions that say, no, we're only going to take students from this university because we're affiliated with that university. And so those of us who may not have a hospital affiliation are kind of like hung up and stuck. Like, where do we find preceptors? How do we get adequate preceptors that are really trained and give our students a good experience? So this iHuman might give us some support in that. And we might be able to drop some of the face-to-face clinical hours and replace them with a simulation in the graduate program, which we haven't really used simulation in the graduate program other than a few OSCEs.
All right. So that was a lot from Dr. Beerwaltis. So hey, Barb from Cleveland. Hi, thanks for being with us tonight. Hope you're enjoying our looking back on COVID. So Laura, tell us, now you're the nursing educator. Give me your thoughts on that.
Well, I thought that was very interesting. And many of the things that she was talking about in terms of like the iSim, iHuman, and things like that are things that have been, that we've been using. I think there were like a few points that I thought about it. One is that I think nursing schools around the country, it's just critical, right, that we are continuing to contribute to the workforce when you think about this big health challenge that we have in the U.S. And so I think kind of kudos to the nursing faculty who've had to be very creative and flexible in helping our students be educated, well in this complex environment. But I think there is a commitment to the nursing profession and commitment to assuring that there is a workforce that can, address this health crisis and those that are going to come. I think one of the things that it seems that nursing schools are sort of going to, because of the surges that are happening in different parts of the country, and sort of what we saw was that our clinical sites that we had, if there were increased numbers of COVID patients, there was concern in the clinical site of having students in the site. And so often the site would be closed to students. And then we would have to kind of flex to more simulation types of things. But of course, that we value the actual, hands-on with patients, we would try to pivot back into the site. So I think what the challenge is now with these surges is schools that have to kind of go back and forth and be very fluid about how they can manage those, and also kind of manage the risks to the student, both them as individuals, and also the risks in terms of COVID in spreading to other students and things like that. So I think for us, and I think for most schools of nursing, it's a very planful and measured approach that emphasizes, I think, student safety and patient safety. And we're doing a lot of like, if this scenario happens, then this is what we're going to do. If it looks like this is going to happen, then we've got our plan B, and sort of plan A, plan B, plan C, with very thoughtful things about what we're going to do. And then if there's this result, then what are we going to kind of flex back into? But I think ultimately it's just I think just really trying to plan ahead, and then having that nimbleness. And I think one of the things that they're going to say is going to happen on a lot of healthcare profession education is that there wasn't, I don't think, and I think generally educators would agree, a lot of nimbleness in terms of education, in terms of having these really strict requirements around this many clinical hours, and you had to be in this situation and that. I think that they've had to realize that within the pandemic, that some of those things, are they evidence-based, that a student has to have this number of hours of this to be able to graduate, or things like that. And so some of the accrediting bodies and different things like that have had to really take a firm look at that and say, what is truly required to graduate a healthcare professional who's able to go and provide safe, quality patient care. And I think that that's actually going to be a great thing going forward rather than a bad thing. But right now, it's a big challenge for I think nursing education and healthcare education in general.
Yeah, I think that's a good point. Nursing education has been extremely rigid, and the boards of nursing have been very rigid. And, so has for medical education as well.
Mm-hmm.
As soon as the pandemic hit, man, we lost our medical students, we lost nursing students.
Mm-hmm.
It's like, wait a minute, isn't this what we do?
Yes, right.
This is what we do. Where are they going? This is a great learning experience. But of course, we didn't have the PPE, to support all of that.
And I think there's more too, even around like typically, in nursing school, it was sort of like, if you want to be a nurse, you have to be here in this setting and do this thing. And I think there's been much more in the pandemic about kind of students managing their own risk a little bit and saying, you know, is this too risky for me given maybe my health conditions or some things like that too, which is kind of a different sort of conversation than typically is had with nursing school as well.
Right. I mean, we've never, I was in nursing school when HIV first came around,
Mm-hmm.
And that was a big thing, and, we were, concerned about our safety with it, about it. But it was never, I mean, we had HIV patients that we took care of, and it was never a choice,
Right.
oh, you can or you can't take care of this patient.
Yeah.
It's like, no, you're a nurse,
Mm-hmm.
go.
Right.
So, so I feel a little old. Student get a COVID patient. If they shouldn't have to take care of a COVID patient. I get it, but if you have someone that is more in the low risk, I think they should be able to. I don't think they should be able to, I don't know, you get into this whole fairness thing, but I think we need to, we shouldn't coddle them. We shouldn't coddle them at all. They need to be out there. They need to be seeing COVID. They need to be learning about COVID. And I really wish that the nursing schools wouldn't be, actually it's the boards of nursing and the governing bodies of these schools that are more at fault for being in the schools themselves. Is that, now, why don't we have kids back in school right now? Why are we waiting till the fall? Why, we have surges in Arizona, Texas, California. I can understand those students not being in school right now, but why don't we have our nursing students right now getting nursing hours in Michigan when we don't have this big surge right now?
Yeah, and I think that probably there are some schools that are maybe thinking about that, about how they can kind of like shift, clinical and didactic to kind of take advantage of these sort of times when there's low COVID activity in their communities and get in there. And I think the thing about, kind of coddling students or something like that, I think really what this is about is sort of measured risk, right? And sort of I think because of it being so unknown, I think I think from a nursing education perspective, it's sort of like helping using science and evidence to kind of guide these decisions about students so that they are, that they have, that they learn and then they do learn about COVID or whatever, but that they're not put in an environment that places them as an excessive, risk. And I think, or their families. So I kind of think what we hear a lot, like in the general education community, is sort of like maybe I as a student, and that would be the same as HIV. Maybe it's fine for me to take that risk. I want to become a nurse, and I might, catch HIV when it was really, like you say, a new thing that we didn't know a lot about back in the 80s or whatever. But I think there's some concern, like, what if I take it home to my children or my grandparent, or if they're in a multi-generational household and things like that, that are, considerations that we have to kind of be sort of responsive to their, concerns about their safety. So that's sort of where we've kind of come from, is more of a place of really listening to the students, listening to their concerns, and then actually having a really evidence-based, strong action plan so that they can get good clinical experiences, but with measure to address those risks, I guess, is how I would say.
And that's exactly why I'm not in nursing education, Laura.
Yeah.
I'm that tough preceptor that says, look, you're going to see this.
You're going to see this and you've got to be there. Yeah, that's right. No, and we need people like that to kind of keep nursing honest, but it's sort of a thing of, it's something that you have to kind of balance. So, yeah.
I get it. I get it.
Yeah. Yeah.
That's why we need people like you and people like me, right? But yeah, I really wish we would see some nursing students though right now while things are opened up, where they can get back to learning, and not just learning COVID, but learning about all the ththings that we always see.
Oh yeah.
Before things start surging and before we start having an influenza and a COVID, season, which I mean, it's just inevitable. We can't get rid of it. So I just wish there would be some planning right now and letting these students get their hours before, they really run into trouble. And there's no, it's great that we have all these other types of learning, the SIMs and all of that, but there's just nothing like a real patient, that's not, and that's where they really learn, getting their hands on and, seeing the emotional aspects of how the disease affects people is huge too, and their families.
Yeah, and actually, it's students that value that as well. I think it's that it's a mutual thing. I mean, I think that's why they go into nursing, is they have that desire to connect with patients on a real, human, close way. And so, I mean, it's our students are the ones that are saying, "Oh, I'd, love to be back in as soon as I can." That because that's truly what they value. And I think it is more about the nimbleness of the curriculum, of being able to say, you were registered for this course, and we're going to switch it, and now it'll be another course that's a clinical course. That some schools of nursing are able to do that in an easier way than others, but it has, financial aid implications, for what they've registered for, and, all kinds of things, auditable degrees. And so a lot of these things that could be, seem like easy fixes are just so complex from a education perspective. But I think the general principle, like you say, if we could get them in while we could, fabulous idea.
Yeah. Well, something that I've never, I taught clinical nursing for a long time, and I taught a year of nursing in the classroom and clinical too. And, I've never understood why people always had this underlying feeling that, okay, we're learning this in the classroom right now. So your patients, try and give them patients that, are reflective of what we're doing in class right now in lecture. I never, well, I mean, I kind of get it, but sometimes those aren't always the best patients for them, And if we took that thinking away, we can totally separate the clinical part of it from the lecture part of it, which it should be separated, because then you could have students doing clinical hours right now and not in lecture. I mean, I don't understand the thinking behind all of that. And then why do their clinical hours have to be done, at a certain time in the semester before lecture, the final exam? And that boggles my mind.
Yeah.
That's where we have a lot of the rigidity in nursing education, that we really need to get to be a more flexible,
more flexible education system. Yes. Yeah.
Absolutely. Yeah. And I bet the students would love it. I mean, can you, we have students now that are adult learners. They're working, they have kids, the folks going into nursing school aren't coming straight out of high school like, they were maybe back in the day, when I was in school. So just all, about being more nimble. So hopefully someone out there is listening.
Well, I was going to say, I think your idea.
All right.
Yeah, no, that's it. I was going to say your idea, though, definitely has been applied to things like behavioral health, where they realize that sort of like mental health coexists a lot with physical illnesses. And so thinking about, rather than kind of people going to maybe a psychiatric facility, right, students going there, but that they could really apply behavioral health and mental health within, like, for example, an acute care setting. So someone who has lupus, but they're depressed, how do you manage that? And then I saw where some of our viewers had made a comment about definitely the need for preceptors and also exposing nursing students to rheumatology, which I totally agree with. I think that there's not nearly enough emphasis around rheumatology in nursing schools, which it really would help, I think better prepare us to have students like join Kathy and the various ones that have been on these Facebook live calls that are such wonderful clinicians, that we would have some nursing students join you guys and help continue.
Yeah, and part of the problem, I've had some really great nurse practitioner students with me in rheumatology, and only one of them has been able to get a rheumatology job. And she did it though moving out of state. So, if we just had more jobs out there that we could offer them, I think we might have even more, staff and more of a workforce.
Has it been your experience that there's more like advanced practice nursing jobs in pediatric rheumatology versus adult rheumatology, or is that just something?
No,
not really. Okay.
There used to be a little over 300 pediatric rheumatologists in the country. Now I think it's below I'm sure it's below the 300 mark now.
Wow.
I'm not sure how much below it is right now, but most of the pediatric rheumatologists work in an academic setting, and a lot of them have nurse practitioners in their practice. I'm trying to think. I don't know of any practice that has more than one in pediatrics, but I'm not sure. But there aren't very many. What I would really like to say, and yeah, here she goes again. So I live in Michigan. I live with some of the most archaic nursing laws in the country, okay? And if we could practice autonomously, I can tell you right now, I'd have at least 4 nurse practitioners doing pediatric rheumatology with me, and we'd be covering the parts of the state that nobody wants to go and travel to and see patients. And and most likely they'd be Medicaid patients, and we wouldn't care. We would be happy as anything.
Yeah.
But nope, can't do it. That's all I'm gonna say.
No. I mean, Georgia is with you on that. I think that's one of the things, though, that the COVID-19 pandemic, though, has been in terms of a positive, and there's not a whole lot of positives, right? But that it has kind of helped create a sort of a situation where I think healthcare legislators and various ones have recognized nursing and their ability to contribute to the workforce. And so we recently, I think in Georgia, had some legislation to kind of increase the ability for nurse practitioners to order like diagnostic tests and things. And it would have been something, I'm not sure that the governor signed it yet, but it definitely went farther than it had ever gone. And we were really pleased about that. And it's restrictions to practice that prevent nurse practitioners from practicing at their full scope and really having that ability to change the lives of patients, particularly, like you say, in rural areas and underserved areas.
Yeah, and especially like a field like pediatric rheumatology. I mean, that's a subspecialty with an incredible shortage. Why can't we do more for these patients? And just to throw out another wrench in things, Michigan actually has a business law on the books that nurses are not allowed to own healthcare businesses.
Wow. That's very restrictive. Yeah.
Autonomously, but not under my own shingle. So
right.
I don't know. So we have work to do.
Yeah.
So any of you Michigan legislators out or anybody want someone to join one of your advocacy groups, I'm all about it. Just shoot me an email. All right. So we have one more video I'd like to let's take a look back on, and that's with Dr. Betsy Kerchner, and she's talking about reinfection with COVID. So let's cue her up, and then we'll come back and we'll talk again.
So is there any talk, Betsy, about how long this immunity might last for? I know it's all new, but what are they saying? What's the word on the street, Betsy?
There's all the words on the street, Kathy. All the words you can think of are on the street about this. So, you look at the models, there are 4 coronaviruses that, have been circulating for years that cause what we think of as common colds. And their immunity is not long lasting. That's why you can get them over and over. Not typically, year after year, but after a few years, you can get that same coronavirus cold again. That's not excellent news. But this one, if in the beginning, was looking more like a longer lived immunity. The small subset of patients they were able to do IgG and IgM antibody testing on and stuff, it looked like the IgG was persisting at least, in the months range. So this would obviously be like the Wuhan cohort, because they were the first large cohort. But now these reports are just coming out that either patients who they thought were out of the woods, maybe they're just sort of having a relapse of their original infection, which would be much better than what could be a possibility, which is that they're getting reinfected. That they, you sort of get this idea that, well, I had it, so now I can relax a little bit, and they're ending up sick again. So are they sick again because they just never really totally cleared it and they tried to do too much, just like can happen with any viral infection, or are they getting reinfected? So hopefully not that, but the jury's still out.
So it could be like an EBV where they become reactivated. Is that what you're saying?
Less reactivated and just not, they just never really totally cleared it in the first place.
Okay. Interesting. That's quite fearful, actually.
Yeah. Very scary.
Thank you, Betsy.
Yeah, Betsy the downer.
All right. Well, it was nice to hear Betsy's voice again. Yeah, that was a real interesting talk when we had that one, and that was fairly early on too that we had that conversation. So I don't know that much has changed since then, Laura. What do you think?
No, I don't think much has, but as she was speaking, I was thinking about that. No wonder there's so much complexity about how we reopen, right? When you don't really have a good timeline for recovery and what does it mean to be truly recovered or not, and some things like that. And so it just kind of reiterated to me of just about how complex this situation is for planning for all kinds of different sort of activities, and major institutions, whether it is academic centers, sports, anything where you have public gatherings. Because to me, just having a clarity about who's sick and who's not sick and who's likely to get sick again or not, and none of that is very clear or well delineated, presents a lot of challenges. So I think there's still, again, I think that's been the common theme through all of this. It's like we know a lot, but there's so much more that's really kind of unknown. And hopefully we'll get some of those data that'll help be able, guide us in a lot of these different arenas, mainly in healthcare, and I think, in rheumatology for sure, but then just more broadly.
Yeah, I mean, it was interesting because listening to that conversation, that's a conversation we could have had today.
Mm-hmm.
I mean, it wouldn't have changed because we still just don't know enough. But I think it's interesting to think about when we're looking at kids going back to school.
Yeah.
And, we have I don't want to get too political here. We have a president that is really, really, really struggling to keep this economy open, to keep people at work. We know that's the best thing for people's mental health and for children's mental health and safety. But at the same time, the CDC has put out recommendations and guidelines for schools opening, which I have yet to read all of them. But the president hasn't agreed with that. And so I'm going to pick through them this week, though, and kind of see what's happening with those. But, it just kind of it makes you wonder, with no one really knowing what's happening with infection. And we have teachers that are going to be exposed, janitors, we're going to have, it tends to be more middle-aged, men and women that are working the heating systems, old heating systems in these buildings, and, doing maintenance and custodial work. And, it's not just about teachers and students, there's a group of adults that are in these buildings that are going to be at risk as well. And not to mention that a lot of these students are going to have younger siblings too.
Yes.
I haven't really, honestly, I haven't been keeping a good pulse on care is doing right now. If childcare is open or how open or where, but that's something I'll look into for next time as well. But it's a very complex issue, and you're right, with people not knowing how you're going to, it's on, and there are other people that just have this prolonged, sequelae of symptoms and are really struggle to get better and even be productive at work and, at their home life. So, at least they're, on this side and not, the other side of COVID.
Right.
But we still have so much to learn. We're learning all the time. It was really nice to reflect back and see where we were. I just want to mention a couple comments that we had from Barb. So Barb said that she thinks that by doing some of the changes in education that we were talking about, that we could weed out some of those students who might not otherwise make it. And I think that's an interesting comment, because I've had students that were excellent in lecture, in classroom, and were horrible in clinical. I mean, like horrible, like I didn't want them in my clinic space, horrible, which that takes a lot to do. I mean, I'm tough, but seriously, I'm fair. And I'll work with anyone and try and get them to where they need to be. But I think that's a very valid point. Also, Barb was commenting that she thinks that teaching on a specialty that students are interested in and not lecturing on everything. I don't know about that, Barb. I know that when I started in nursing, I started in the emergency department in adults, and we saw everything. So I actually was using everything I learned in nursing school. There wasn't anything I didn't learn in nursing school that I didn't use. And I think that's held true with every job that I've ever had. It all goes back to anatomy and physiology at the very beginning. And we still use that to this day. And I've been a nurse for over 30 years. So I think it's very important to continue lecturing on systems and diseases that we've been, lecturing on. Nothing has changed with, anatomy and physiology throughout the years. The diseases have changed some. But I think that if a student is interested in a particular specialty like rheumatology, I think there should be more flexibility with clinicals. I think that would be a great idea. And I think more flexibility with that would be a great idea. I could definitely incorporate a lot of things from med-surg into a rheumatology clinical for someone. In fact, a lot. And let's see, what else is she talking about? Barb was saying that, she thinks that office nurses and hospital nurses should be taught separately. I beg to differ with that, Barb. Sorry, but my thought is that Yes, they're very different. I agree. The problem is that when you're working in an office in a clinic and you're triaging patients, you need to know signs and symptoms of other things than your specialty that you've been trained on. The only way to do that is to go through nursing school and learn everything that you learn in nursing school.
One thing I will
Clinicals that you've had.
One thing I will say, though, Barb, that I think is really important in what you said, and I agree, with what you say, Kathy, is one of the things that at Emory we have a faculty member, Dr. Caroline Coburn, and she actually wrote a book that'll be published soon called Ambulatory Care Nursing. So sort of what we found was, and I think this speaks to the idea of kind of like a specialty nurse in an office setting and things like that, and how that nurse can practice to the full scope of her license in that setting and not be just doing something that a medical assistant would do, right? The idea is that we in nursing had not really had a clear vision of nursing within outpatient settings and how they would practice. And so Emory, we changed our curriculum to where there is now a course in ambulatory care nursing where they actually have the opportunity to do clinical in an outpatient setting, not a hospital setting, and see kind of the work that you were talking about, Kathy, a very complex work of triaging patients, listening to someone on the phone and being able to know, whether they should go to an emergency room or not, or helping them make transitions in care. They've just been, discharged from the hospital. What do they need to do? And some things like that. And I think that has been a really important sort of way that nursing education is advanced. And so we're sort of interested in seeing, kind of the outcomes of that in terms of how we're educating our students, and whether more of them, I think, will choose more of the specialty ambulatory care areas to advance their practice.
I think that's great. I think you definitely should have an ambulatory care, curriculum to your clinicals. Definitely. It's really hard sometimes getting nurses to go from the hospital setting to an ambulatory setting.
Right.
It's going to be boring. It's going to be whatever. And ambulatory nursing is everything but boring.
Mm-hmm.
And it's no weekends, no holidays, no woohoo! What's there not to love about it?
Yeah. Yeah.
And you actually have a more intimate relationship with your patients in ambulatory care as well.
Mm-hmm.
So lots of great rewards with ambulatory nursing, that's for sure. So yeah, it's all about nursing education. I have lots of thoughts on nursing education. Some may not be too popular and others might be.
Mm-hmm.
I'm always happy to give my opinions. As those who know me know too well. But anyways, thanks, Barb. Those were, great comments. Barb. Definitely. So to wrap it up for tonight, and thank you for joining me tonight, Laura. It's been fun, and it was great taking a look back at COVID and seeing how far we've come and where we need to go. And until next time, everyone, stay well, stay safe, and until next time, see you later.
Bye.